Buenas tardes, bienvenidas y bienvenidos. Muchas gracias por estar con nosotros en este seminario. Voy a presentar a nuestros ponentes antes de darles la palabra. Nos acompañan la doctora Shani Campbell, que es economista senior en el Grupo de Desarrollo del Banco Mundial. Su investigación se ha centrado en incentivos financieros, dos tipos de incentivos financieros, transferencias de efectivo a los hogares y también contratos de pago por desempeño a proveedores de servicios de salud. Ella también es profesora adjunta en la Universidad de Georgetown y editora asociada del American Journal of Agriculture Economics. También escucharemos hoy al doctor Demian de Wok, quien es el economista líder en el Grupo de Desarrollo del Banco Mundial, en el Banco Mundial también. El doctor de Wok tiene un doctorado de la Universidad de Chicago y sus intereses académicos, su investigación se ha centrado sobre todo en temas de educación y salud y la interacción entre educación y salud. Actualmente su trabajo se enfoca en evaluar el impacto de incentivos económicos a la salud para mejorar resultados de salud y de educación. Él tiene una larga trayectoria de investigación en el Banco Mundial y es el principal autor del World Bank Policy Research Report, Improving Effective Coverage in Health, enfocado en incentivos financieros. Vamos a escuchar entonces la presentación. Ellos nos van a explicar su trabajo. Al final vamos a reservar algunos minutos para comentarios o preguntas. Y muchas gracias otra vez por estar aquí.
Hola, buenas tardes a todos y muchas gracias por su invitación y su hospitalidad. Y Shani y yo estamos muy contentos de tener la oportunidad de presentar nuestro informe sobre investigaciones relativas a las políticas de desarrollo titulado ¿Cómo mejorar la cobertura efectiva de la salud? Funcionan los incentivos financieros. Nos gustaría poder presentar nuestro informe en español, pero como ambos estamos todavía aprendiendo el idioma, creemos que será más cómodo para todos si continuamos en inglés. No obstante, nos gustaría señalar que existe un panorama general del informe en español. Está disponible como PDF en línea y también tenemos algunas copias con nosotros aquí. También está disponible en línea una versión en español de nuestro PowerPoint. Y en inglés ahora. So it's a pleasure for Ishani and I to present our report called Improving Effective Coverage in Health. Do financial incentives work? It's in the World Bank Policy Research report series. It's the work of a large team, including the two of us, but also Adam Wagstaff, who was our manager and who unfortunately passed away 2 years ago. And also our colleagues Jet Friedman, Sven Nielsen, Moritz Piatti, Femkirken, Anja Sootman, Gil Shapira, and Ellen van der Poel, all World Bank colleagues. So what is our starting point for this report is what we call the frustrating statu quo that we can illustrate with these two maps. So the first one is showing across the world that there are still high rates of antenatal care visits around the world. So that's data from 2017, and you see here around the world the rates of pregnancy for which the woman had at least one antenatal care check, and the darker the color, the better. the higher the percentage. And you see that for a lot of countries, this is very high. It's 70, 80, or even above 90%. So in terms of access to care for pregnant women, things seems to be doing well, with a few exceptions in a few countries, mainly in Africa. But if we look at the end health outcome, at maternal mortality rates, we see a different picture. Here we are looking at maternal deaths per 100,000 live births across the world, and still things look good in many countries, but we see that in a lot more countries, we still have stubbornly high maternal mortality rates, unacceptably high maternal mortality rates. So there is a disconnect between utilization and outcomes. And the way we think about this disconnect is, as economists, we think at what economists call the principal agent problem. So the principal agent problem is basically when you have an employer and an employee, and in our case, the employer would be the Ministry of Health, the employee would be a doctor or a nurse, and basically they are tasked by the employer to provide services, quality health services. But the problem is that for the employer, the amount of effort of quality of care that is provided is difficult to observe. What the employer can observe is the outcome, whether the patient survived, is in better health, etc. But the problem is that the health outcome, as we all know, is not only and entirely determined by the effort. Even when doctors or nurses do their best, sometimes the outcome is adverse. So that's at the core the principal agent problem. It's common in health, it's common in many markets, especially in the public sector. It's the same with education, for example. So to deal with the principal agent problem, people have introduced what is called performance pay, or pay for performance. So paying for performance, as I said, is a common approach to deal with this principal agent problem. And it basically ties prices to actions. So there is a list of things to do, and we are going to pay the agent for every service that is provided or every action that is done. It's used across public sector bureaucracies in the world, with application in education, infrastructure, agriculture, etc., including health. And the goal is to improve the efficiency of public expenditures. Performance pay is based not only on the quantity of the service delivered, but also the quality. Otherwise, you run the risk of only having the numbers increase, but at the detriment of quality. So it's very important to also contract quality. And it's important to know that it's, for example, in the health sector, it's a big shift from input-based financing, which was the norm in many countries before, where basically someone in the center would determine how much money you would need, how much staff, how much equipment, how many drugs, etc., and they would provide it in a centralized fashion. No, it's really moving away from that, and there is a lot more transparency and accountability. So, and as I said, we are going to look at this in health. It's one example, but it's important to keep in mind that this type of approach is common in many sectors. So now let's look at basically what these performance pay, or we'll call them also performance-based financing, or PBF projects in health entails. And basically it's a package in intervention that includes 4 components. First, the performance pay that I just briefly described, and then Ishani will give more details. It's one important component of this package, but it's not the only one. There's also more autonomy for the frontline health facility. They get more money, and they have also more autonomy about what they can do with that, with those funds. there is also, by the very mechanism of paying for performance, more transparency and accountability that is established, and also stronger engagement with the community. And those changes also often bring substantial effects on the public financial management systems. So at our institution, the World Bank, there's been a large effort over many years to promote this approach. Performance pay, there was a trust fund called Health Result Innovation Trust Fund, which was basically invested in performance-based financing approaches, especially for maternal and child health care in low-income countries. It was very large, about $2.5 billion. It's spanned about 15 years and 40 countries. And what's important is that it was not only projects to implement PBF, performance-based financing, but also together with it came impact evaluations, rigorous impact evaluations with rigorous randomized controlled trials, etc., to try to figure out whether or not these reforms had an impact and which type of impact. And that research component brought a strong collaboration between the World Bank Research Group, of which Ishani and I are part, and our colleagues in the health sector teams. So basically, this report, the objective is to figure out what we've learned from these pilots. So, and you know, when you look at the results from many impact evaluation, you can say, well, some of the results were positive and statistically significant, some were not. And it's tempting to say, well, you know, it's the story of the glass half full or half empty. In our book, in our report, we try to go beyond this and ask specifically 5 questions. The first question is, what does the evidence say about performance pay in low-income country health systems? We assess the impact of performance-based financing on coverage and effective coverage. I will define more in detail what we mean by effective coverage, but for the time being, please consider that it's health coverage with a minimum content and quality. And so, as I said, the book is focused on maternal and child health services. Second question that we are asking is, what are the key constraints to quality? Which constraint could, and also more specifically, which of these constraints to quality can effectively be addressed by performance pay? And can we realistically expect it to improve quality of care? And if yes, by how much? Third question is whether demand-side approaches improve coverage and effective coverage of maternal and child health services. So, and we are going to do a comparison between demand-side incentives and supply-side incentives. PBF is a supply-side reform. Fourth question is, how do performance-based financing projects compare to what we'll call and further define direct facility financing, and we'll use the acronym DFF. And finally, we'll ask what are the key lessons for the design of health financing reforms. So here is a, oops. I don't think we are seeing here you're supposed to see a map. I don't know, it's strange because the previous map worked well, but this one is basically showing you a geographic, a map showing the geographic scope of the report, saying basically the report takes evidence from a lot of countries in low and middle income countries, including evidence from Mexico, also so from Latin America, Asia, quite a lot, and you'll see today more of a deep dive in the evidence from countries in West and Central Africa. So I'm sorry about the map. I hope it's the only thing that it's not showing. So let's come back to the distinction between performance-based financing, PBF, and direct facility financing, DFF. So if you remember, I just described the 4 main components of PBF projects: performance pay, operating budget autonomy, transparency, accountability, and community engagement. Well, DFF is basically the same component, except that you remove the explicit link between additional payments and performance. So basically you cross out performance pay. Ishani will again come with more details, but basically that's the snapshot I want to you to remember for the time being. So now let me, before we go more into the details, give you a sneak peek at our key takeaways. So first, we find little evidence for impacts for across the board performance pay in under-resourced, unfinanced health system. Okay, so few impacts. We also find that direct facility financing, which I just defined, with autonomy and accountability for the frontline health facility, can deliver many of the same gains at lower cost, and also they are relatively easier to implement. So what we suggest for teams that want to embark in health reforms is that before designing health financing reform, do some sort of assessment. First, assess coverage versus effective coverage to identify low-hanging fruit for performance pay. Second, assess constraint to quality of care to ensure that they're in a place that they're in the locus of control of the frontline worker. So basically that the frontline worker can act on these constraints to quality. And finally, it's important to keep in mind that baseline utilization should have room for improvement, because otherwise it doesn't really make sense to incentivize if you're already very high, but also not to be so low that they may be more indicative of demand side barriers. We also suggest to more often combine demand and supply side approaches. And also we think it's useful to sequence intervention and use performance pay more strategically for those indicators where it makes more sense. So now let me come to this concept of effective coverage that I briefly described before. So what is effective coverage? So it's coverage that includes a minimum content and quality of care. And we like to think of it as the product. So effective coverage is the product of two components. The first on the left is coverage, and on the right is quality. And coverage is the percentage of person in need of care for a specific medical condition X who actually consult a medical provider. That's coverage. And then quality is among those people who consult, the percentage who get relevant care. Okay, and so effective coverage is the product of these two measures. In the report, we operationalize effective coverage by investigating how to measure it using existing data. What we do is we use household survey, existing household survey, mainly demographic and health survey and mixed survey from 93 countries, and we show effective coverage and how it varies by country, by wealth level of the patients, and also depending on the medical condition. It's important to say that we not only look at when there is not enough care, so insufficient care, but also when there is too much care or irrelevant care, what we call overuse. That is also an issue. So to illustrate the concept of effective coverage, we'll take one example of antenatal care, and we look at it in 5 African countries. So in this graph, on the horizontal axis, you have coverage. And for antenatal care, the coverage is just the percent of women giving birth with at least one antenatal care visit. Okay. On the vertical axis, you have quality. And quality is defined as among those women who had at least one visit, the percentage who had at least 4 visits, one of those visits with a skilled provider for whom at least one's blood pressure was taken and blood and urine samples were taken. That's the definition of correct treatment according to WHO guidelines is the minimum. So that's quality. And you have it on the vertical axis. And so we draw this line, we call them effective coverage contour. They're like ISO curve, and they link different points, different combination of coverage and quality that will give you the same level of effective coverage. So let's look at these 5 African countries. If you look only at coverage here, you see that there is not too much of a difference. For these 5 countries, they're more or less around 80 or above. So if we were looking at coverage only, we would say, well, you know, some progress still to do, but not too bad. But the situation is quite different if you look at quality. You have one country here, the Republic of Congo, that the capital is Brazzaville, doing quite well on quality and on quantity. And so the effective coverage is around 70. Then the 2 next countries are doing okay in terms of coverage, but quality is lower. It's around 60. That's Cameroon and Nigeria. And as a result, effective coverage is already lower at 40 or 50. And the 2 next countries, Central African Republic and the Democratic Republic of Congo, again, not too bad in terms of coverage, but quality much lower. As a result, effective coverage, it's below 40. And actually for the Democratic Republic of Congo, it's just above 20. Okay? So with that, I'll give the floor to Ishani.
See if I can lower this to my level. Apparently not. I guess I'm just too short for the mic. And this, okay, wonderful. You see the pointer? Oh, yeah, there. Doesn't seem to be working. It worked once, then. Okay, sure. Sounds good. Okay, thank you. Okay, so with that rather dramatic introduction, let me talk a little bit about, you know, as Damien pointed to, there are these problems of quality. What they boil down to is, in terms of the effective coverage concept, why the rate of relevant treatment is not 100%, which is to say, why aren't health workers doing everything that they know to do and they're able to do, given what is available to them at the facility in terms of equipment and drugs and supplies. In the economics literature, the smoking gun is often thought to be health worker effort. In other words, you know, workers are just shirking, they're not doing things that, you know, they could fully do if they wanted to, that it's their effort that's the problem here. If that's true, and if effort is observable and it's contractable. Now, remember, with the principal agent problem, effort might not always be observable, but for a moment, assume that it is observable, it is contractable, then performance pay might make a lot of sense, right? Because then what you're trying to address is the health worker's effort, and by tying their actions to their remuneration, you might actually be able to elicit a greater level of effort. However, when we actually think systematically about the constraints to quality, what becomes very quickly apparent is that the constraints to quality, in fact, lie at several different levels. The first might be the level of the facility, or potentially a higher level in terms of problems of equipment, of shortages in drugs and supplies. Thank you. And I'll try not to break it again. Now, you might think this should lie at least with the facility. If it doesn't lie with the health worker, fine, but it's with the facility. But, remember in centralized health systems, often if there is a stock out, you have to go through the centralized procurement system. So this might not even be in the facility's locus of control. It might lie further upstream in the form of problems in medical training, gaps in health worker knowledge that stem from inadequate training. Again, there might be centralized curricula that have to be fixed for this sort of problem to be addressed. And there might be issues with the public expenditure tracking system, wherein if there are substantial delays in the disbursement of salaries, then workers might, be demotivated. They might not want to show up. And if you're not paid your salary, not wanting to show up, I think is not an unreasonable response. Then, of course, there's the issue of health worker effort, wherein health workers might not actually do what they can do. And this is what performance pay tries to address. There is a further issue, which is that of patient-driven demand, which is that certain patients might feel more empowered or informed or able to ask for or purchase certain services, and others might not. And health worker effort might actually interact with that sort of patient-driven demand. We're not really going to get into this last component a little bit, but just to acknowledge that it's an important barrier to high quality care, and we'll talk a little bit about it. But the main point of this exercise is to point out that not all constraints to the quality of care is in fact not all of these constraints are in fact with the health worker. They might lie at different levels. And so ex ante, there may be important limits to what performance pay, which is really designed to improve worker effort, might even achieve. We can formalize thinking along these lines by decomposing into 3 gaps that are formalized into a no-can-do gap framework by Ibnath and others. The first of these 3 gaps is the structural capacity gap, for which we need data on the health facilities and infrastructure. So what's available in terms of drugs and supplies and equipment at the facility. The second is health worker knowledge, for which we need vignettes with health workers to assess what it is that they know. The third is sort of what we're interested in, which is underused capacity or idle capacity, or the effort gap, which is what health workers are leaving on the table. So once you say, given what's available at the facility, what you could do, what you know to do, you should be doing everything else. But what are we actually observing you do in patient-provider interactions? That's what we're trying to improve, right? That's almost never 100%. For this, we need direct observations of patient-provider interactions, right? So this is a data-intensive exercise, but given this impact evaluation portfolio that Damien described, we can do this sort of decomposition for 5 countries. And these are the 5 that he showed you in that effective coverage map just before I arrived and proceeded to break every piece of equipment here. So we have rich data from that impact evaluation portfolio on health facilities, on patient-provider interactions, on health worker knowledge. And what we're going to do is do this no-can-do gap decomposition using the WHO protocol for antenatal care as the benchmark. So there may be some small differences in national protocol, but we're going to look away from those, and they're minor in any case. And what we're going to do is we're going to assess both manifestations of poor quality that Damien referred to, which is underperformance and overuse. What we find is that they both exist at the same time. So at the same time, health workers aren't doing everything that they're supposed to be doing, and doing things that they're not supposed to be doing that are at best unnecessary and at worst potentially harmful to the mother or the developing fetus. Okay, the first set of results. So here on your left is the summary results for structural capacity gaps. On the x-axis here is the percentage of facilities that had the particular item in stock on the day of the survey. On the y-axis is the relevant item that is needed for antenatal care provision. This is a subset. In the book, you can find the full list of equipment and drugs and supplies that are needed for antenatal care as defined by the WHO. The first takeaway here is, each bar is a different country. For each country, for health facilities that are supposed to and in fact do routinely provide antenatal care, for every single piece of structural capacity for physical infrastructure, there is in fact far from universal availability. Even, things like relatively well-provisioned things like fetal stethoscopes or anti-malarial medication, in some countries, we get up to maybe 90%, but we're really not seeing levels of 100% across the board for any of these items. Similar results where there are knowledge gaps for every single action that is supposed to be performed. Not going to show it to you, it's in the book. But then when we put it all together here on your right for underused capacity, here we have the percentage of underperformance that explained by no can-do gaps or underused capacity. And on the y-axis, again, a subset of the relevant actions per the WHO protocol. Two key takeaways here. The first is, once again, for every single action, there is some underused capacity. So it is indeed true that workers are leaving some quote unquote money on the table for every single action, but overall those sizes are relatively small. On average, we're talking about a maximum of a third of underperformance being explained by underused capacity. In other words, what that means is that 2/3 of underperformance does not lie with worker effort. It lies elsewhere, primarily in structural capacity, but also in problems of medical training. What this means is that these are settings where there are many competing constraints, and performance pay is unlikely to be a silver bullet. It's unlikely to be the solution to the problem, the entire solution. We also find that wealthier women are 3 times as likely to receive high quality care as poor women, even in the same facilities. Now, we don't necessarily think this is all about discrimination. This could be about patient information. This could be, a bunch of other things, but certainly there can be a component of discrimination. What this does is it points to, first, the fact that the worst off facilities within countries are, much worse off than the best performing facilities. So there's a lot of room to improve the poor performers and gain that way. But there's also the role for things like user fee removal for patient information drives within these countries as another approach. And so while health system financing remains a challenge, it has to address several things. It has to still address capacity gaps, structural capacity gaps. It has to address health worker knowledge and also health worker effort, but not only health worker effort. Going back to what Damien said about ways in which we can do this, we think that before designing health system reforms, we should be assessing coverage versus effective coverage using available household surveys to do that sort of mapping to see where there are problems of quality, and then to assess the constraints to quality in this no can-do gap framework sense, to really understand what the drivers of poor quality are before we try to address them. But so let's see what has been done in the health financing space to improve effective coverage. And a lot of this literature, a lot of this investment has focused on performance pay, for which there is in fact a fairly well-established body of evidence from high-income countries, which are decentralized, well-resourced systems. The NHS in the UK uses performance pay, Medicaid in the US uses performance pay. These are not systems with competing constraints, and they're really, paying providers to improve their performance, and that's it. Even so, the record of success of these interventions is quite mixed. The evidence is quite mixed, especially when it comes to quality. Furthermore, what we're going to be talking about in our report are applications to very different types of systems. These are centralized. These are, frontline facilities don't have autonomy. They don't have an operating budget. And these are, as Damien described, these are umbrella interventions that are trying to do several different things. They're trying to address those structural capacity gaps alongside improve health worker effort. So this isn't the sort of targeted performance pay intervention that we might be familiar with from the US or the UK. This is a very different type of intervention. Even so, the early evidence, in particular from Rwanda and Burundi, from low-income settings, was quite promising. The PBF could, in fact, improve service delivery in particular. So Damien described the big picture of PBF projects. Here's a concrete example using prices from Nigeria. Health facilities received 4 performance bonuses for workers, $12 for every woman who gave birth in the facility, $1.20 for an antenatal care visit, and 80 cents for a fully immunized child, using MMR as the proxy. In addition, they received an equal amount that was calculated every quarter for unconditional infrastructure budgets, essentially, unconditional operating budgets to these facilities. They could use it for anything they wanted except for staff bonuses. In addition, there was a transparency and accountability reform that was really important, wherein facilities reported their performance along these purchased indicators that are up there every month. And then based on these, they receive payments. And every quarter, a third-party audit agency came to every facility. So in the Nigerian pilot alone, there were 1,100 facilities. So you can imagine that sort of audit process becomes very expensive very quickly when we're talking about scaling this up. And then based on those verified reports, your payment would either continue as calculated, or you would get an adjustment in the next quarter if there was falsification. And in addition, there was often a community engagement component. So in terms of the scope of the evidence in this report, just a few caveats. The first is that most of the evidence is going to come from Sub-Saharan Africa that we are going to talk about today. These are where the first generation and even the second generation of PBF projects were implemented. That's what we have to draw from by and large. And the first generation of projects generally use the prices to improve quantity, but there were always some measures of quality as well. So we do think it's fair to assess them on quality. We will, of course, spotlight where relevant high and middle income country evidence on other approaches, including non-pecuniary ones. And then this is primarily antenatal care, but we do touch upon non-communicable diseases and curative care. But the basic question is, what is it that we learned from these donor-financed pilots to inform the scale up of these sorts of health financing reforms using domestic resources, using government resources? The first set of comparisons that informs this is that of PBF projects versus business as usual. On coverage, we don't really have a whole lot new to say. There's a 2021 Cochrane review by Diakonu and co-authors, which finds that in most contexts, PBF projects did, in fact, in these LMIC settings, improve at least some measures of coverage. On quality, what we can do, however, is assess impacts on structural quality and on worker effort using that no can do gap framework. Now, again, this is a data intensive exercise, so we have limited data, but I'll show you what we can say. So on structural quality, this is an illustrative example from Cameroon and Nigeria. Here's a summary of results. Let me talk you through this type of graph because I'm going to show you a few of these. So these forest plots are going to show you the treatment effect, the estimated treatment effect of PBF here for structural capacity. 0 is no effect, and then these would be increases, which is a good thing in this context. And then decreases would be obviously negative, would be a bad thing. The negative effects would be here on the left of the vertical line. Above the horizontal dotted line are summary indices. So an overall index of structural capacity and overall drugs index to point to issues of supply chain. And then the components below, below the dotted line of these indices. And, just sort of the takeaway from this graph is that there are always at least some positive effects. The significant ones are solid markers, and the insignificant but estimated increases are sort of left open. There are some, but far from across the board effects on structural capacity. When we put it all together and we look at underused capacity, again, for the same two countries. Now, remember, underused capacity is a bad thing. This is what we want to reduce. If anything, we're seeing very few and actually no precisely estimated decreases in underused capacity. If anything, perhaps some increases, which are quite concerning. Now, these are just two countries, but these are often viewed as two successful examples of those early stage PBF designs. So we think it's safe to say that overall there is no reduction in underused capacity from this approach, and maybe some increases that we think are the result of the role of user fees in these settings. Don't have time to go into this. This is one of my personal favorite portions of the report. Please do look at it. But a concern that often comes up is that PBF can replace intrinsic motivation with extrinsic motivation and thereby leave a demotivated health staff, especially once the PBF project has ended. So we bring together RCT evidence from Central Asia and Sub-Saharan Africa, and we actually don't see any evidence of this. So we think this is not a grounds to criticize PBF. That said, we also don't think there's a lot of grounds to go for across the board PBF, even compared to business as usual in the settings that we're seeing. The fact that the largest impacts are on structural quality is not surprising, given that that's where we actually saw the constraints as lying, right? But that then raises the question, are there more cost-effective ways of bringing about structural capacity improvements rather than having this very expensive performance pay component with the verification angle as well? So what are some other ways that you might improve structural capacity in other dimensions of quality? So what we're going to do is we're going to compare on the demand side cash transfers and voucher programs to PBF and direct facility financing programs on the supply side. We're going to present them as a sort of a horse race, but they should and often are used and should be used more often in comparison. So this map works. You can see that the evidence we're pulling from is really from across the world, but a lot of the PBF and DFF evidence is going to come from, as Damien said, West and Central Africa. So on the comparison to demand side, what we're going to rely on is a systematic review and meta-analysis by Damien and some of his co-authors that pulls evidence from 52 programs from 30 countries. And what we look at here are impacts of PBF compared to voucher and CCTs for 6 indicators tied to maternal and child health, 2 of which are measures of effective, 3 of which rather are measures of effective coverage, and the other 3 are of simple coverage. The first takeaway here is that for all 3 of the intervention types considered, it is true that the impacts are generally speaking positive. So financial incentives do improve service delivery. That said, the mean effect sizes are modest. And in general, it is the case that vouchers and CCTs actually do a little bit better than PBF. So for example, the one indicator where PBF often does improve service deliveries or coverage is facility delivery. And there you can see that the PBF impact is 4.5% compared to about 6.5% for vouchers, 7% for CCTs. So even there, PBF is not necessarily being, it might be outperformed by other alternatives. So on the supply side, as Damien said, the key comparison is to DFF, and the big difference is the lack of performance pay. Another difference between PBF and DFF, though, is how the transparency and accountability are delivered. So in PBF, there is this very expensive verification mechanism that I described. For DFF, because the financing they're receiving is unconditional, there's nothing to verify. At the same time, most of these projects included business plans or dashboards, much lighter touch, less expensive, but still impactful ways of delivering transparency and accountability. In this HRITF portfolio that Damien described, there are 5 projects that compare these 2 approaches side by side, and we can look at them. These 5 are Cameroon, Nigeria, Rwanda, Zambia, and Zimbabwe. 3 of them also included comparisons to business as usual, so we can also look at that for those 3. And then for 2 of them, for Nigeria and Zambia, it's important to remember, as I show you the results on the next slide, that the PBF interventions actually dispersed twice as much as the DFF intervention. And here's what we find. With the exception of institutional delivery, some of which is actually driven by a switch to deliveries in publicly owned facilities, we actually find no significant differences between PBF and DFF, or even comparing to business as usual. Now, the y-axis here, there are a lot of different measures of coverage and effective coverage. And the point of this is just to show you that we cast a wide net. We really did look to see if there were any differences between PBF and DFF, but by and large, we don't really find any impacts. There are other important considerations that we delve into in deep dives in various parts of the report. We'd really encourage you to take a look at it. It's a 300-page book. One of which is that the baseline coverage levels, as Damien also alluded to, can be really important. In addition, there's evidence from a growing number of countries, also from high-income settings, that performance pay might actually work best in hospital settings or higher settings and not the primary health center setting, because there are fewer constraints competing constraints higher up. Those are better resource settings. So the performance pay is going where it's intended to go. There's also evidence on the impacts of PBF and private sector contracting. And then finally, on cost effectiveness, we have sort of three implications. The first is that there might be task complementarity that you can leverage, and there's a growing body of evidence on this, theoretical and empirical, that can make contracts cheaper. That prices can be used as a signal of importance, that they might actually be playing a non-pecuniary role as well, by signaling salience of the task. And then finally, by using pecuniary and non-pecuniary tools, you might actually be able to improve the effectiveness of the financial incentives when they're deployed. But the bottom line that we're gonna leave you with for financial incentives is that, yes, they improve service utilization and some measures of quality sometimes, but these impacts are small and they leave a lot of room for improvement. And in under-resourced centralized settings, we really do not see evidence for across the board performance pay. As Damien said, it should be deployed strategically. In these sorts of settings, flexible operating budgets and associated transparency and accountability reform can be really meaningful in and of themselves without incurring the additional costs and the complexity of design of performance pay interventions. I will try to leave without.
Thank you very much, Ishani. So we'll try just now to very quickly to wrap up and point on the operational implication of the findings in the report. So just to summarize, the key takeaways from the evidence is that there is little evidence for impacts for across the board performance pay in those health systems which are under-resourced and unfinanced. On the other hand, direct facility financing with autonomy and with accountability can deliver many of the same benefits at a lower cost, and it's also much easier to implement. One of the issues with performance pay is that it makes the budget unpredictable, both from the point of view of the government as from the point of view of the health facility. And also in performance pay, there are large verifications which are necessary to enforce conditionality, but they are substantial. For example, in Nigeria, there were 2/3 of the administrative costs of the project. And so we conclude that performance pay is often a complex intervention which can be difficult to scale. So let me finish with a few action items that comes not only from the evidence, but from what we have observed on the ground for the last 15 years. We think, as we said, it's important to start with some diagnostics and assess coverage versus effective coverage to identify which are the low-hanging fruit for performance pay, and also identify what are the gaps in structural capacity and in health worker knowledge, and measure this no-can-do gap that Ishani has explained. And so once you have done that, we think that the sweet spot for performance pay might be where baseline utilization has some room for improvement, but is not so low as to be indicative of barriers on the demand side, and also where there is a high level of this no-can-do gap. We also think that sequencing of the intervention is key. Maybe start with, for 18 or 24 months, demand-side interventions and direct facility financing, then repeat that diagnostic above, and then introduce performance pay for select indicators. And also we would recommend using emerging technologies to reduce the cost of implementation, such as mobile money portals and dashboards. So let me finish with 5 principles which we think should be important for health financing reform. The first one, and a very important one, is to send as much possible of the funds to the front line. The second one is to ensure transparency and accountability through good facility financial management. The third one is introduce routine supervision when necessary, but that should be supportive. The fourth one is introduce an output or performance orientation, but we know that it's not absolutely necessary to use performance pay to do that. It's possible to do it, for example, through dashboards and portals that record the number and the quality of the service provided. And the fifth principle is to unify the payment system. And with this, thank you very much. Muchas gracias. And we are open for your questions and comments.
Muchas gracias. Tenemos unos minutos para comentarios o preguntas de aquí o a las personas que están conectadas. Creo que vamos a ver las preguntas acá, que no hay todavía. Acá, sí.
No, but there are no online questions, but there were two in the room.
Thank you for the very nice presentation. Very interesting results. I was wondering a bit about the motivation part also. Sorry, Helene Vermandre, working here with Sergio. Yeah, I don't know what else to say about myself. Anyway, so I was wondering the motivation part. So I get that if health workers could get extra salary because of the performance-based program, that would motivate them. I get that when the program stops, it can demotivate them. But I was also wondering, like, because of everything you said, like you have to have, like, from what I understood at least, you have to have a kind of basic health infrastructure and knowledge among your staff before it can actually start helping you, or before you can see an impact. So I was thinking about the following situation. If you work in a health center in a more rural area and your health center really doesn't have a lot of equipment and the supply is really hard to get, every time there's delay and whatever. And so then you have a pay for performance program. Maybe you can earn a bit of money more, your salary, but there's also the part of for the hospital itself or for the health facility itself to use. Like, are there any studies that show, and maybe I'm going into extreme now, like how it can demotivate people because you're working in a hospital in a very rural area, and now they're asking you to work even harder to get like what you should have. And then maybe you have health facilities closer to a capital area that have everything already, and they too can get bonuses and so on. So like, I feel like in these situations where the basic equipment is lacking and where it's really hard to work, like a pay for performance program can almost have the opposite effect. Like, now I have to work harder to get like very basic equipment and so on. So I was wondering if one of the programs had showed something, or would that be or is what I'm saying not making any sense?
So do you want to answer that one before?
No, let's take a couple.
Can we take another one and then maybe?
Well, thank you so much for your presentation. It's very enlightening because we really need to know how to improve quality of care, especially in prenatal and child health and during pregnancy. I am Dr. Pera. I am a researcher here and a professor in epidemiology. And I work in the gestational diabetes area in underserved communities here in Mexico. So my question is about performance pay, as this other colleague is asking, because I wonder about this systematic research. Well, I mean, this meta-analysis that you performed, and of course is based on very underserved communities in sub-Saharan Africa. But even in other countries, like in Mexico, for example, how can you pair up with comparing what you are searching for, doing this strategic plan, but also taking into account that the government has its own rules and their own different ways of, paying for the services, and enlightening with motivating physicians and medical care workers to do that. So how can you, relate? There is a relationship between what the government does against what all these WHO rules are. Of course, they're not contradictory, but they are different. So how do you take into account what the governments are doing compared to what you are trying to do? Because sub-Saharan Africa is the most underserved in the country, in the world. But in other countries, you have other guidelines that you have to follow up on too. So that's my question. How do you pair up those, research questions with what's going on politically in each country? I know it's very hard to answer, but that's my question. But thank you very much for your very interesting talk.
Want to go?
Motivation comes. It's on. Okay. Yeah. So on motivation, that's a really it's a really great question. Thank you for asking it. It's certainly true that there's a relationship between motivation and the physical infrastructure of where you work, right? I mean, we can all attest to that. We don't need sort of a grand theory of worker motivation for that. And similarly, just a signal from the government that what you're doing, or your supervisors, what you're doing is a value, can be really transformative. So having said that, it's not clear to me which way this effect of PBF would go. Would it in fact, because PBF does in fact also bring all this additional money, these umbrella projects, right, into the facility's overall quality. And that's not tied to the workers' effort. They're getting these unconditional funds. So they're making things better in some ways. So there might be countervailing effects. But on the other hand, it could be, well, yeah, I'm just supposed to be doing this. This is my job. Now you're asking me to do all these other, jump through these other hoops. So this is very much part of the body of theory that says that PBF might, or performance pay might end up with might leave you with a demotivated staff when the incentives run out. But that's at least not what we find in this setting. In general, also where there has been from other settings, from other high-income country context, for instance, analysis of the impacts of PBF and motivation, we actually don't see that that theoretical concern borne out in empirical reality.
Yes, if I can add something on the first question before going to the second question. On this, you took the example of these remote facilities compared to the center. In most PBF programs, there is what they call a remoteness bonus. So that basically if they do more, they will receive more in the faraway health facility than the facilities in the capital, exactly to try to recognize that it's much more difficult to achieve it in a rural remote facility, but doesn't answer all the problem. So to the second question, so if I understand well, your problem is, you say, well, you are using these WHO guidelines, but in each of these countries, you have different guidelines that might be different. That's true. So that's why, the comparison I showed was using the WHO minimum guidelines, but in the systematic review and meta-analysis, we just took 6 indicators, which we think they might not be, many countries might require more, but basically it's family planning, it's delivery in a health facility, is at least 4 ANC visit, at least 1 postnatal care visit, anti-tetanic vaccination for the mother, and complete vaccination for the child. It has been quite a lot of work in looking at all the papers to try to basically find indicators that are similar and I think we did a relatively good job in the paper. We described that, but basically, so we took these 6 indicators, and for some countries there might be a very low bar, and for some other countries there might be a high bar. But we decided, let's compare these programs all across the world, these vouchers, this PBF, and this CCT on these 6 indicators, which we think is sort of the minimum. I mean, it's basically, if you have impact on these indicators, that means you have a good impact on essential elements of maternal and child care. So that's the approach we took. But we recognize that there are a lot of difference across countries in the way, in the guidelines, and also in the way, in the context and the way these different programs are implemented.
I can just add one thing to that. You know, you said something about how these guidelines are political, and we completely agree with you. And there's sort of a public financial management aspect as well. And so just to plug a paper of ours that was published today, Damien and I wrote about some of this, still engaging with the health financing evidence, but getting in a little bit more into the PFM side of things, into the overall political economy setup. It was just published in BMJ Global Health. So please have a look at that as well.
So I'll ask one question while we see if there are other questions online. Can you talk about motivation as one of the critiques to PBF kind of programs? I think the other one has to do with sustainability and cost effectiveness of this type of programs. There's one paper I really like by Paul Gertler, where he looks at the PBF program in Argentina, and he talks about organizational inertia or something like that. And he finds that the PBF program basically pay for the cost of improving, but once that was the improved services were the new normal, and you remove the incentives, then the standard of care stayed. And I think that was a very nice example of as a counter argument of sustainability, or as a response, one possible response to sustainability and cost effectiveness. Can you talk about that and what you found in other places?
Yes, I mean, that's the example of, I think, the Misiones province in Argentina. Yes, it's the dream result to respond to the questions about sustainability. I don't know that we've found it in many other places, because in the first place, to have a sustained effect, you need to have an impact in the first place. And as we've, I mean, there are some impacts, but not across the board for a few indicators. So, you know, the Plan Nacer, I think Plan Nacer and then Plan Sumar programs in Argentina are a very successful example of PBF, but maybe in a different context than those African contexts where there is already a well-functioning, well-equipped health facilities, etc. So maybe PBF was the right approach for the Argentinian health system, and then they had impacts, and then further found sustained impact even when you remove or decrease the incentives, which is what you hope. But in other contexts, well, as I said, to have sustained impact, but it's also, to be fair, we don't have evidence except that example of Misiones, where we really went, except maybe some of the papers look at longer run impacts, and at least in Africa, they are not really there, you know, these papers by Sebastian, etc.
Yeah, I mean, I think one thing, so I mentioned that very briefly on my penultimate slide, right? When talking about other ways to improve cost effectiveness. And so one thing to remember is that is that impact on neonatal mortality decline is in higher level hospitals, which is where all of the evidence of performance pays effectiveness really comes from. So that begs the question, whether we should really be thinking about that as an instrument in primary health settings in low income countries. On cost effectiveness, I think the biggest question that comes up with performance pay specifically is that of verification. In Argentina, I forget what the verification mechanism was, but they have a very robust HMIS system. And so verification costs are much lower. This is a high quality system that you're imposing this on. So when you introduce these verification schemes, you also have the opportunity for collusion, for gaming the system. You're doing a lot of things to really underdeveloped, under-resourced settings that at least I personally find very uncomfortable to think about.
Yeah, thank you. I don't think we have questions online. So in Mexico, I'll just end up with a common question. We're going through a reform in Mexico of the health system, where in this country we have, I think, a pretty robust data health information system. We have pretty good coverage in many aspects, but issues with quality of care and remoteness is also an issue. So what would be your advice for Mexico based on your report?
I think, if you say that there is coverage is high and always good, and the issue might be more quality, maybe a systematic look at, effective coverage, doing this sort of exercise. In the report, we do it not only for antenatal care, but also for hypertension, TB. So basically trying to see where quality is way below what it should be. And then try to see what are the constraints to this quality. Is that equipment or training? Then, address those. And maybe, as we said, look for, if you want to think about PBF, look where really the problem with quality is really something that the health worker can have control on, and try to then introduce potentially them there, but not, I don't think, well, I guess from our conclusion, PBF is not the silver bullet, but I think this simple exercise, and I'm sure you have plenty of existing data to try to identify, first of all, where there are big gaps in effective coverage. What is the source? Is it coverage or quality? And what are the constraints to quality? That's already an important starting point.
Yeah, we have this diagnostics exercise in the overview that lays these steps out. And so in addition, next step would be, once you identify the problems of effective coverage, you do the no-can-do decomposition to understand even within quality where the problems are. Figure out, for example, if the frontline facilities have an operating budget, if they can respond to stockouts, things like that. And then, as Damien said, sort of layer things in slowly. And that also gives you time as researchers to assess the impacts of the things that are being layered in.
All right, thank you. Well, thank you very much for your presentation and for coming and visit us here in Cuernavaca to INSP.
Thank you.
Thank you.
Thank you. And help yourself with some of the books or overview.
Muchas gracias.